It's what you won't hear that you may notice first. The sirens, a near constant noise in the world of paramedics, are silent.
From that moment right there, that was it. This is what I wanted to do. I was born to be a paramedic.
Austin Travis County EMS Captain
My entire adult life.
Mike Sasser.
I was 19 years old. This is what I've been doing.
Isn't driving an ambulance, though.
Getting to do this, I can't even put into words like the motivation and the desire and the excitement and the fulfillment I get from getting to do what I get to do, because I see real results.
He's driving a small
I think there is one simple answer.
SUV.
Trauma.
A mobile clinic of sorts.
You know, we say trauma leads to addiction. A lot of people are like, okay, so somebody experienced something bad, some kind of traumatic event, and now they want to escape from it, and so they use drugs, right? That's not the reality of what it is.
On his way to meet a patient, we'll call Sarah.
Sweats or chills at all?
Sarah is mother to a newborn.
Restlessness?
And with the birth of her new baby comes her determination to be newly sober.
Okay, there he goes. I got a number.
Normal is something Sarah hasn't experienced since the birth of her first child, when she was prescribed opioids for pain. And that prescription would lead to an opioid addiction for nearly a decade.
My first prescription was in 2014. I'm not sure when I realized it was a problem, but at some point it became a problem.
But people are using every day and they're getting sick every day, and so they need help, and so our program is designed to basically support you while you're getting in there and make it so you don't have to use anymore. Okay.
It was late 2020 when Mike Sasser decided that after 30 years as a paramedic, he was ready to do something more. It started as a way to give life-saving drugs for overdoses.
I thought, I'm going to give some people some Narcan, and then somebody's going to call me up and be like, hey man, I used that thing you gave me to save somebody's life.
But the need kept growing.
I realized very quickly, like, we're going to need a lot more Narcan, and we're going to need to do a lot more, and this isn't going to be enough.
And it turned into the buprenorphine Bridge program. Buprenorphine, an FDA-approved medicine that stops withdrawal symptoms and cuts down on cravings. Mike and his team give the drug to patients waiting to get into rehab.
Let's talk about starting small and going slow.
A process that can take days, even weeks.
I'm looking through, and actually what I'm looking through is this is how many I have to look at.
Each morning, they check the overdose reports from the day before.
Okay.
And revisit those addresses.
So just go follow up and say, hey, are you okay? Is there anything we can do? And offer connection and offer resources and say, hey, we're here if you need us, and just let them know that when they need us, that's what we're here for.
In less than 4 years, they've already helped more than 200 patients.
I imagine they're a little surprised when you show up at the door the next day.
Quite often.
That's 200 plus people getting treatment to try and get off drugs. Instead of relocating the problem, they want to solve the problem, bridging the gap between addiction and recovery.
I'm still in contact with people that we started in the very beginning. There's one particular young man that we worked with in the very beginning of the program. He's now got 2.5, I think, years sober, and he's actually in law school.
Not every case leads to sobriety, but Sasser and his team won't give up.
I know that every day they're going to wake up sick, and they're only going to get sicker until they do whatever it is that they have to do to satisfy those feelings, to not feel miserable, because that's what addiction's really about. It's about just not feeling miserable.
He knows firsthand the toll that addiction can take.
And this is personal for you.
It is.
Can you talk to us about that a little bit?
Like so many people,
Sorry, I might need a minute for that one.
Sasser struggled with opioid addiction.
Can I step outside for a second?
Yeah, absolutely.
Early in his life. Understandably, it's not easy to talk about.
You're doing amazing. It stayed in the back of my mind for a long time, and I still didn't feel comfortable talking about it, so I didn't. And then all this happened, and the clients started asking me, like, hey man, you get this a little too much. It's like, what's up? And I never hesitated to talk about it in front of them, right? Because I know they weren't judging me.
And as he's opened up, he's realized it's become a tool for his work to connect to patients like Sarah.
Did you get to the point of the chill bumps too?
No lights, no sirens, just helping people as long as he can.
I think more people should know about it.
So Christa, we've seen a lot of you lately, obviously, in the news. A lot of news has come out, of course, about all the opioid epidemics and the overdoses that are here in Austin. It slowed down a little bit, thank God, right? But talk to me about what it's been like for Austin Travis County EMS, I would say just over the last couple of weeks, as far as all of these calls that y'all have been receiving seems to be particularly centered downtown.
So, you know, when we started to see the overdose surge, we got lucky because they started in a very concentrated area, and some of them had multiple patients on them. So that raised the index of suspicion pretty quickly that we were dealing with something. And, you know, as soon as we recognize, hey, like, this isn't normal, people don't normally overdose on an opiate in groups all about the same time. And our community health paramedic team just almost immediately mobilized. You know, they saw what was happening, they piled a bunch of Narcan in their car, and they hit the streets, essentially flooding the city with Narcan so that we could see that spike start to drop back off. But you know, it wasn't where it started downtown. It sort of just grew out from there, almost like little tentacles of an octopus. So, you know, it started concentrated downtown. It moved down I-35 and a little bit east, like East Old Turf area. It got all the way out to Burleson Road. So you saw it start downtown, and it just expanded out from there. And it, you know, it got a little dicey there for a while. It was putting a strain on our resources, but you know, because the community health paramedics mobilized so quickly to get out there and try to prevent any more of these from happening, I think that without that, we would have seen it get even worse.
With EMS crews, in this case with opioids, what are the patients typically dealing with when you guys get on scene? Is there still a danger aspect to it?
So certainly not as much as with K2. You know, when we saw the K2 outbreak in 2015, the problem that we had with K2 was keeping track of all of the different kinds of it, because there would be one batch in town that was made with beta blockers. So it would drop people's blood pressure, drop their heart rates, they could go unconscious, and then there would be a different batch that came in, and these people were, you know, hyper agitated, combative, and things like that. There's a lot of things that differentiate, you know, the K2 outbreak versus this overdose surge, but you know, we didn't see the number of deaths from K2 that we see with opioids, and that's why opioids are so dangerous, because they'll kill you dead if you take too much of it. And the other unique thing that we saw with the surge, most of these people were not trying to use an opiate. Most of them were trying to use crack cocaine or methamphetamine.
We know from the news and other cases that fentanyl is laced in drugs that people are taking in any socioeconomic class, that these are kids in high school that are thinking they're taking a pill when it's a Percocet, when in fact it's laced with fentanyl. So what message would you like to send to people? You know, it's summertime, people are going to be out partying, they'll be out downtown, maybe they're out on their boats. You're thinking you're taking something that's a prescription from someone else or whatnot, and you're taking something laced with fentanyl, and you have no idea. And it's not even the drug that you think you're taking.
Yeah, you know, I think it's important to stress that, you know, particular to the surge that happened a few weeks ago, there were some unhoused patients that fell victim to that. But that surge didn't discriminate. We ran calls on people in their offices, in their houses, out in public and businesses. So it really, the surge was not an unhoused issue. The surge was an overdose issue. And we saw it cross age demographics, racial, socioeconomic. It just didn't discriminate. And that's indicative of the opioid epidemic as a whole, right? It doesn't discriminate. Almost everybody in this country knows somebody who's been affected by the opioid epidemic. With fentanyl being put into pressed pills that were meant to mimic legitimate prescriptions, you know, that spread like wildfire. And it hit literally every demographic on the planet. Kids in high school, you know, lawyers in their office, doctors before they do surgery, like it hit everybody, and nobody was immune to it. So, you know, I think the take home from both what we've learned during the surge that we had a few weeks ago and what we've learned, you know, sort of overall as we navigate the crisis, is that if you're taking a substance that was not prescribed to you by a doctor, dispensed by a licensed pharmacy, you're taking a gamble. You're never going to have absolute proof of what is in that substance. Even if it's your best friends and you think it's the Xanax that their doctor prescribed them, you don't know.
They weren't even intending to take it.
Yeah, and the take home is, you know, obviously we don't condone anybody doing drugs, illicit or otherwise. But it really, the things that we've experienced really show us how important harm reduction strategies are, and some of the efforts that our community health paramedics have taken with the Narcan kits that made an absolute difference in what we saw. But at the end of the day, one pill can kill. You can take a half of something that you thought was legitimate and wake up dead.
And I think too, the harm reduction with the Narcan, the message that you guys are trying to work on putting out there is really important, because we spoke about it off camera earlier, but don't use alone is another big message. And what do you tell people when you do say, if you're going to use, here are the steps to at least try and take to stay safe?
We know that people are going to use. It's just a reality of the world that we live in. So anything that we can do to make that as safe as possible is beneficial. So, you know, doing things like starting with low doses and going slow when you're using, making sure that you have somebody with you who's staying sober and has Narcan available and can call 911 if something happens. It's incredibly important. And, you know, as we saw, just because you don't usually use opiates doesn't mean that you shouldn't carry Narcan, because whatever it is that you are using could have an opiate in it. And I mean, better safe than sorry, right?
Yeah. Do you see a world in which we all just have to carry it just in case?
I mean, I carry Narcan on me wherever I go. If I'm going to concerts, I'll put it in my purse.
Wow.
You know, I have a kit in my car. I have a kit at home. It doesn't matter what sort of lifestyle you lead. If there's something that you can carry that's small, portable, easy, cheap, and it can save a human life, I think everybody should do that.
That's interesting. It's like a cell phone. I mean, is this the world we live in now? Do you see this changing anytime soon?
Not anytime soon. You know, I don't think that this kind of thing is probably ever really going to change. You know, I think that as we see the opioid epidemic morph and evolve, we may see new substances. You know, 10 years ago, nobody knew what fentanyl was.
Right.
Medical professionals did because we use it.
Right.
But nobody knew what fentanyl was in the general public. And before that, it was OxyContin. So, you know, as we sort of see these things change and evolve, we'll have to evolve with them. But I mean, I honestly don't see a world where there's no more opiate overdoses.
Yeah. I mean, and I'm assuming the training that you guys do has constantly got to shift, right? As these different drugs are becoming more and more prevalent in drugs that people don't even realize they're taking. The response that you all have to provide has to shift with that as well. How much training is involved in retraining when these different strains of drugs come out into the market?
Yeah, you know, it's case by case. When we had K2 happen, that was a sort of a summer of horror, but K2 never went away. But, you know, we did continuing education on the different patient presentations, and, you know, like I was saying earlier, with the different types of K2, you treated them in different ways. One person you might need to give a bunch of fluid to because their blood pressure is too low. One person you might have to sedate because they're fighting you. So, you know, we call it a practice of medicine because it truly is a practice. It's never perfect because things are always changing and evolving.
Does this one scare you a little more than some of the others, though, because it's so sneaky?
You know, it certainly adds another level of complexity. You know, when you are talking about people who were not intending to take something that turned out to be an opioid, and now they've overdosed and they've stopped breathing, and you're going through your differential trying to figure out, like, okay, how am I going to treat this patient? You know, if the person that they were with said they smoked crack, you have to make sure that just because they smoke crack doesn't mean it's not an opioid. So you constantly have to have that in the back of your mind and have a high index of suspicion for it, because opiates have gotten into everything.